Welcome, everyone. I am Scott Perry from Cook Children's Medical Center in Fort Worth, Texas, and I will be your host for the next hour and a half or so as we talk about epilepsy surgery and all of those burning questions that you might have had and wanted to ask but haven't asked, or too scared to ask, or forgot to ask. Now's your chance. This is going to be very informal conversation. This is going to be like a visit in the clinic, hanging out, asking questions. No question is a bad question. I am happy to answer anything as best I can. If I can't answer it, I'll tell you I can't answer it. But like I said, there are no bad questions you can ask about all things related to epilepsy surgery. We will kind of have this split up into some sections. We'll talk about when and why a person should consider epilepsy surgery. We'll talk about what kind of options are available for epilepsy surgery. There's lots of different kinds of surgery. We'll talk about outcomes and how you choose what are realistic outcomes. And then we'll talk about what the evaluation, the whole process looks like when one undergoes epilepsy surgery. I am going to be joined by some awesome caregivers. Diana and Jamie are joining me. They'll give their pieces and kind of their feedback about the surgical experience as well, and their advice. And I'm going to speak for them and say they're also open for all questions and happy to answer. No question is a bad question. All right. And then Helen is somewhere. She was somewhere. There, she's back there. Tell you, the lights are bright. They're hard to see past this. So, okay. So, I wanted to kind of start just to kind of get a feel for who's in the room. So first, my first question is just who in the room has a loved one who has had epilepsy surgery already? Sure, I'll count VNS. Okay. So, all right, now I've got all these people with hands in the air. Is VNS the surgery you've all had? Has anyone had a surgery other than a VNS? Yes. Okay, great. Do you mind me asking what surgeries? A DBS placement? DBS. Corpus callosotomy and an RNS. Okay, great. And okay, so that will mean that the rest of you do not have a loved one who have had epilepsy surgery, but you must have questions about it. How many people have been told by their treatment team that their loved one is not a candidate for epilepsy surgery? Okay, and would you mind sharing why they said you were not a candidate for epilepsy surgery? Uh-huh. Okay. All right. And what kind of seizures were they trying to help? Okay. So they were trying to...
I think it was generalized, and they couldn't pinpoint a spot to place the electrodes or whatever they're called.
Okay. So they were looking for a focal area of the brain to operate on.
Correct.
Right?
Yeah.
Okay, we'll talk about that. That's rarely an epilepsy surgery that will benefit a person with LGS because it's not the kinds of seizures they generally have. But there are other epilepsy surgeries that can be used to treat.
That's what I'm here for.
Can be used to treat those seizures. Do you mind sharing?
My daughter was evaluated for surgery, epilepsy surgery, in 2023 in Texas, in the Children's Hospital. Was a second opinion, and they tell me that she have LGS, they cannot find like a focus, and she's not candidate for laser or ablation, things like that. So that was the tell.
Was it my hospital in Texas? Okay. I mean, everyone in Texas has a cowboy hat. That didn't help me one bit. I say, okay, all right, okay. Yeah. Okay. Sure. Reasonable. Okay. And just one other question: how many people here have gone through a surgical evaluation or discussion about surgery? You've been told your child is a surgery candidate, and you chose not to pursue surgery. Kurt, you mind sharing the reason why you chose not to at the time?
So at the time, we were looking at the corpus,
Mhm.
and between getting ghosted by our pediatric neurologist and Addison starting to recover in her seizures, we didn't pursue further.
Okay. Great. Okay. Oh, yeah, go ahead.
For me, it's about quality of life.
Mm-hmm.
My son is 6. He's never had a seizure-free day since he started having seizures, and I'm scared to rock the boat. I feel even with daily seizures right now, he has a very good quality of life, and I'm afraid if we go in and mess around that we could change things.
Okay.
So surgery for me is an option if he loses, that good quality of life, if that makes sense.
Okay. Yeah.
Yeah, I think we're in a similar boat. Our neurologist suggested the corpus as well, and we're right now in like the evaluation phase. I think part of it is worsening quality of life and just also understanding if that's the next step or if there are other options right now as well.
So that's good. We'll talk about all these procedures and what your fears and thoughts are so we can go through kind of the conversations we have about these procedures. Yeah.
I was just going to add the same thing. It's the quality of life. We haven't started the conversations with his epileptologist yet, but I know they're on the table. But I've been hesitant because he's so happy. He's got a great attitude. He does have the seizures. He does have delays, but I'm worried that it'll change who he is.
Okay. Okay. Very reasonable. All right. Do my parent caregiver folks have anything you want to add before we dive into the sections?
I guess I should move up front. So, so we were evaluated a number of times over the years. For those of you who met Billy, he's 40, so we've had a chance to be evaluated a number of times for different surgeries. And there have been times where they've come back and they've said, well, we could do this, but we're not sure it would help with anything. And at that point, we've had to say, that's not really an option for us because of quality of life, right? But there have been other times where we've had to make a choice that said, they came to us and they said, we could do the corpus callosotomy. We ran the tests. We think it might help with the drop seizures, which were slowing down anyway, with no change in meds, with nothing. They just decided to start slowing down. We could do the corpus callosotomy, but because of his current issues, he might lose certain skills. There might be these problems because he's older. He was considerably older at that point. And again, we had to make a quality of life decision. So, take your information and look at it seriously from both sides. Eventually, we did decide on 2 major surgeries. So, and I think we've made the right ones, but I think it was important to look at all of those pieces that came together. Jamie, did you want to say something?
So Andrew's 19, so again, on the older side of things in the LGS side of the world. And the RNS was not one of the choices on the table, and the very first thing that actually came through for us was a corpus callosotomy, and they did it the first 2/3, and we had miraculous no drop seizures. Beautiful. 6 months on the dot, boom, they start right back up. 1 year from the date of the first one, we did the last 1/3. That gave us 3 months. So then we went in again almost a year from that one and had a MRIT transsectional that showed there were still fibers connected. They went in that one more time. And I tell you, every time you have to make this decision, Is it the right one? Is it the wrong one? Only you guys know, but you're also the ones that have to live with that decision on the other side, right? And so I hear all of you. Because when Andrew came out of that third time, he had full left-sided weakness and couldn't move for a week. And I thought, oh my God, what did I just do to my kid? He gained it back. He was able to walk and he had all those. But he's had all three of them. We've experienced the VNS, we have the corpus, and we have the RNS. And I'll wait until the end and give you what I feel like helped Andrew the most, but I don't want to.
There's a good question on the weakness. Is he have any residual weakness, or he
Not
just
anymore.
didn't move for
He
a while after the procedure and then got it back?
he got it back.
Yeah,
Yeah,
yeah.
we did some intensive
After the
physical
callosotomy.
therapy.
So,
Yep.
so the callosotomy has a known adverse effect of apraxia. So apraxia is when the brain has to make a plan to do something, and when you cut the corpus callosum, you can have an apraxia, so the body can do it, but the planning, it can't make the plan to do it. And it's not really clear why it happens, but it happens, and then it's like turns back on, you know, days
And then
later,
I
weeks
have
later.
to tell you that after that, the seizures turned right back on.
Yeah, yeah.
They did. The drops continued.
Yeah.
So.
Okay, so we're going to go in, like I said, some sections. So the first, the way we're going to do it, we're going to sections. We'll have a topic. I'll kind of give my little spiel about the topic. You guys will fill in kind of your stuff, and then we'll have just time for discussion. So you can ask any questions, preferably about that topic, because we'll get to the other ones later. So we kind of keep it in order. So first, we're going to talk about when or why should you consider epilepsy surgery. So traditionally, epilepsy surgery is considered for people who have drug-resistant epilepsy. The definition of drug-resistant epilepsy is failure of two appropriately chosen and appropriately utilized medications for the treatment of epilepsy. Why is that important? Well, one, appropriately chosen and utilized. That's important for people, for example, if you have a person who has absence seizures and they were put on oxcarbazepine, which is trileptal, right? And they failed it. That medicine was not a failure. That is the wrong medication to treat absence seizures with. It was not expected to do anything for absence seizures. So that would have been a waste of time. And so that is not a failure. That is poor selection of medication. If you had chosen ethosuximide or chosen valproate and you failed it, that's an appropriate failure. Then, traditionally, people would fail to the high dose. That's what we would consider a failure. We always start every medication at the lowest dose we know to be effective, and we go up in a stepwise fashion until we reach the high dose, and if it fails, then we move on to the next drug. You can technically also fail medication for adverse effect, though many people won't utilize that as their prime reason to call a medicine a failure. They'd rather see you tolerate it, but it just doesn't work. So why do we say two medicines, and why do we call that drug-resistant epilepsy? Well, the reason is, statistically, among all people with epilepsy, approximately 60% of people will be seizure-free with the first medication they try. If they fail their first medication used appropriately, then another 15% will become seizure-free with the second medication they try. That means that 75%, 3/4 of people with epilepsy in the world are controlled with one of the first two medicines they try. If you fail two medicines, statistically, the likelihood that you will become seizure-free on the third medicine drops into the single digits. And every medicine after that, it goes lower and lower and lower. Now, maybe one day that statistic will change. Maybe there will be new medicines that work with a mechanism that's so special and different that it changes that. But so far, that exact study has been done decades apart from each other with many more medicines invented in the meantime, and it hasn't changed one bit. So, I think epilepsy surgery should be considered. Go ahead. Multiple count too. So you start one. I mean, the way things should be done is you start one, you work it up to the high dose. If it doesn't work, you add another one and work it up. Of course, anytime you add a medicine, you need to make a choice. Am I adding and collecting medications, or am I adding and getting rid of medications? That depends on your physician and how they like to do things. I'm a one thing at a time kind of guy. So I'm either going to add something or I'm going to subtract something. And of course, if you're only on one, I'm not going to subtract it before I add something. So, But yeah, 2 combinations count, but you don't have to have a combination. That's not like a, something that you have to prove to have epilepsy surgery. So I start these conversations really early. That conversation right there, that's what I tell people with newly diagnosed epilepsy when I meet them, because I want them to know after 2 medicines, if that were to happen to you, here are the things we do. Because surgery should not be something we're talking about way down the line. Yes?
Have been approved for the epilepsy, right? And some of them work by same mechanism, some work by different mechanism. I don't know how many different mechanisms are for all these approved drugs. First question is, how do you pick is the right mechanism for this particular patient? So as you said, if you pick the wrong drug, it doesn't work because you don't know.
Yeah.
What is the real reason the seizures are occurring in that particular patient?
Yeah.
So is there a way to pick the right mechanism or a combination of mechanism to treat the patient before you make a decision that drugs don't
Yeah.
work?
So in selecting drugs to treat epilepsy, often mechanism is not the first thing I would think of when trying to select the drug. The first thing I think of is what kind of seizure am I trying to treat, and which medicines do we know treat that type of seizure well. For instance, as I said, absence seizures. We know absence seizures, ethosuximide and valproate work the best. Amantadine, which is not an anti-epilepsy drug, it was actually invented to treat the flu, is actually a very good medicine for absence, and then lamotrigine. Now, mechanism comes into account when you maybe have failed some things and you want to do what people call rational polypharmacy, which is where, instead of giving you 6 sodium channel mechanism medications, I'm going to use a sodium channel medicine and a GABA medicine and maybe a calcium channel medicine. It just works a different way. Conceptually, that makes a lot of sense. I'll tell you, I don't really think rational polypharmacy really does much, but it makes people feel good that they thought about it before they did it, but I don't really think it does much. What it does do for you is that often when you use medications of a similar mechanism, you can get more of the adverse effects associated with that mechanism because you're stacking them on top of each other. So if you get a lot of sodium channel drugs, you're much more likely to get low sodium, hypothyroidism, and all the other kinds of things that come with sodium channel drugs. So, but it's mostly about the seizure type, and then etiology. If you know the etiology for the epilepsy, then mechanism may play a role, right? So there are certain genetic conditions, for example, Dravet syndrome, which is SCN1A, that is a sodium channel disease. Those kids do terribly bad on sodium channel mechanisms because it blocks their already dysfunctional sodium channel more, whereas kids with SCN8A have an overreactive sodium channel, and so they need sodium channel drugs to block there. So it depends, but it's mostly on seizure type. So we were talking about when you choose. So first, I said, drug-resistant epilepsy. That's easy. The other recommendations are people who have epilepsy in the setting of an epileptogenic lesion that can be identified and safely removed can be considered for epilepsy surgery even after failure of 1 medication. So an example of that is a brain malformation called cortical dysplasia, which are small areas where the brain is malformed. If we see someone with new onset seizures that has cortical dysplasia, and they fail 1 medicine, we'll think about surgery much earlier. Why? Because statistically, 99% of them will have drug-resistant epilepsy. And if they fail 1 drug, that's all you need to know. And so if it's in a safe place to get it out and save them from a lifetime of medications, we'll go for it. Now, people think about epilepsy surgery for seizure reduction, right? That's their most common cause. And a lot of times, the reason people with LGS get told you're not a surgery candidate is because your doctor's going to say, there's not a surgery that's going to make you seizure-free, right? So you're not a surgery candidate. That is an absolute fallacy and misuse of epilepsy surgery. Epilepsy surgery is no different from any other treatment we have for epilepsy. All the treatments are intended to try to make things better, and that means reduce seizures. After you've failed 2 medicines, as I said, pretty much nothing has a great chance of making you seizure-free, so everything is being considered to reduce seizures, and you deserve the opportunity to hear about all of the options you have to try to make that. Surgeries that are designed to reduce seizures are often referred to as palliative epilepsy surgeries. I'm actually leaving here and next week going to a surgery meeting where we're specifically working at that meeting to come up with a new word, because palliative sounds like it's an end-of-life problem, and that's not what this is. This is seizure reduction surgery. So we're changing how people think about this. Seizures might not be the only reason, and maybe that's not the reason. Maybe you're doing it because you want to, sure, reduce seizures, but really you just want to be on less medicines. So you want to have something that helps you get on less medicines. Maybe you have a certain seizure type that's a problem, right? So you have convulsive seizures that keep ending you up in the emergency room, or any form of seizure that results in fall and injury, that you want to get rid of the falls and the injuries. Maybe you want to improve the quality of life some other way, improve alertness, or potentially decrease developmental regression or something of that nature. It can be used for multiple reasons. You just have to be clear about what the reason is when you go in and discussing it. So do you all have anything you want to add to when and why to choose epilepsy surgery or think about epilepsy surgery? When did you think about it?
So I thought about it for Billy when things were out of control, when we were maxed out on meds. Now, remember, for Bill anyway, this was the 1980s, 90s, so we had fewer drugs to choose from. We hadn't really heard the words LGS, although all the signs were there. And we were really given very few options. So that's when we had to look at surgical options. And then our first, even though we were evaluated with PET scans and MRIs and CAT scans and all kinds of other fun stuff, it wasn't until we decided to go for the VNS that we made that actual decision. And we were told then that chances are that was not curative, that was not a curative step, that was something to ease the symptoms, and that hopefully, if nothing else, it would help him recover faster from the seizures he did have. So it was put into our heads very early on that was the reason for that step.
Yeah, a lot of people, especially with LGS, that get evaluated for surgery, on average have failed 8 to 9 medications before they get referred for epilepsy surgery, which is far too many, far too many. You didn't have to choose epilepsy surgery after you failed the second drug, but you at least need to know that it was an option and compare it to the other 9 medicines they might want to give you and see if it's better or worse than that opportunity. Did you have anything to add?
Yeah, so Andrew was 11 months when he had his first EEG, and on the EEG, he was seizing 9 out of 10 seconds on there, but wasn't clinically exhibiting, or we could explain it, right? Because he had, at that point, hearing loss, so every time he had a jerk, well, that's a reflex from hearing a noise that he couldn't hear before he had hearing aids. So he was 7 when the surgery came on the table for us, and it was because we'd failed so many medications, including ones that were not available in the US yet. We were trying ones that were available from Canada, and that's when it became an option and a decision that we headed towards.
Right. Yeah, so my take homes from this, and then you guys can ask some questions about this particular subject, particular question. But I always explain to people that undergoing a pre-surgical evaluation for epilepsy surgery does not equal undergoing epilepsy surgery. It is just that. It is a pre-surgical evaluation to see if you are a candidate. The other thing I say is everyone's a candidate for epilepsy surgery. Some people are just better candidates than others. That's it. Everyone's a candidate. So let's talk about what the option is, what the risk, what the benefits are, and then also here are some medicines and the risk and benefits of medicines. Here's dietary therapy and the risk and benefits of dietary therapy. Which thing makes the most sense? So it really should be considered much earlier for you to make informed decisions. So anybody in the audience who is currently thinking about epilepsy surgery, you're talking to your doctors and it's unclear of, I mean, do you know what your goals are, or to reduce seizures? Okay, a particular type of seizure or all seizures? Tonic seizures, yeah, okay.
Same, basically quality of life,
Yeah.
reduce seizures, and he has tonics, primarily in tonic-clonics, but he's
Okay.
also very tired every day.
Yeah.
And he likes to be out in nature and doing things, so it's a balance.
And do you think that all that tiredness is lots of meds and treatments, or lots of seizures, or probably both, I'm sure, but yeah. 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 What else? Mm-hmm.
She had, sorry. She had her VNS 3 years ago. This year, we saw a lot of improvement after 3 years of the VNS. Reductions of seizures, better quality of life. We can reduce medicines. She's doing better. She's learning. She's in school. We are thinking about RNS maybe to be like a second push, like a second help. Now she's 13 years old, and I know that RNS take time too. So, but I'm afraid, like other parents, that to do something very invasive that is going to interrupt now her life, what the things that she loves, and later don't see any benefit. So that is, but we are considering RNS. But also, if they can evaluate and they find other area, maybe like other evaluations, and find something more like laser ablations and things like that, we can consider it also.
Great. Okay.
So, so I think I mentioned they suggested corpus. But right now, the main seizure type she has is tonic-clonic and absence.
Okay.
She did have drop seizures, which have been under control for about 3+ years. So they are suggesting corpus because they are saying the medication she's on will be less effective as she gets older. And so they're hoping that through this process, they can start weaning her off some of the medications, but it is currently under control. And so I think that's one of the things which is making us kind of nervous of why are we going through a procedure which is under control, under medication, versus thinking of like, is it, if we do it and then we take her off the medications, like is getting her off the medication the end goal, or is it controlling it right now with the medications as we kind of go
So
through?
a couple questions. What is your definition of control? She's seizure free?
Well, I know seizure free is not gonna happen. Like it's the likelihood of seizure free is, I'm very realistic.
It's not
about that.
zero.
It's not zero. Yeah.
That's what I want you to understand.
Yeah. No, I understand. Nothing
It's
is
not
going to
zero. It's possible.
It's possible.
There are people with LGS who are seizure free.
100%. I agree. I know it's not zero, but
Yeah.
that my end goal is not for her to be completely seizure. I think
Yeah.
I would love for it, but I realistically know that's likelihood isn't. My main concern of going through a procedure like that is the goal that they're trying to fix is already under control with medication. So
I hear you.
understanding is it true that the efficacy of, like, she's on Epidiolex?
Yeah, I don't think they know that.
Yeah.
I don't think they know that. Do we see people routinely like do better with a medication and over time not
Yep.
do better? Yeah, see it all the time. That's what drug-resistant epilepsy is. We see it all the time. But are there some people that find the right drug and it works for them forever? Yeah, those exist too. So, I wouldn't be doing a procedure to predict something that is uncertain, But if you were doing it because you had adverse effects and you wanted to maybe get off medicines, or if you were doing it because you are still having seizures, so you want to see if you can get even fewer seizures, those are reasons definitely to be thinking about.
I mean, I know that procedure won't help with like the absence and some of the other ones because that's not what it's indicated
That's
for.
not true.
It may help.
Corpus callosotomy
It may help, I know.
works for multiple seizure types. It is traditionally thought to be for drop attacks. Okay, drop attacks are any seizure that results in a fall, first of all, so that's not actually a seizure type. Tonic seizures are the most common cause of drops. Myoclonic seizures are actually the second most common, and atonic seizures are the rarest of all seizure types. True atonic seizures where you lose tone and fall are the rarest. But those are the ones that people traditionally think of a corpus callosotomy for. But in fact, absence seizures can be reduced 60 to 70%. Tonic-clonic seizures can be reduced in that range. So it can work for other things. What it's not going to work for is focal seizures. right? It doesn't work for focal seizures. Focal seizures come from one area, so disconnecting one hemisphere from the other is not changing that one bit. Yeah. So, sorry, I got one more question back here, yeah. Or actually, two more.
So I raised my hand earlier when you said, is there anybody here who has an LGS loved one who is not a candidate? We haven't gotten the official word from our doctor that he's not a candidate, but I'm putting him in the not a candidate category because with the medication that he's on, he's had 0 seizures. I know you said earlier that like
For sure.
seizure-free is
Yeah.
not a possibility.
Yeah.
But the fact that he's on 3 different medications, Epidiolex, Clobazam, and Depakote, is that I mean, and he's not, sorry, the quality of life is very good. It's come back, right? From when he got his LGS diagnosis a year and a half ago to now, his quality of life has really come back to, he's actively in he just finished 4th grade, he's going to 5th grade, he's got friends that he plays with, he has things that he enjoys doing. And like I said, we haven't seen a seizure in, I mean, the last EEG he did was September of last year, no seizures on the 24-hour EEG. We've got another one coming up in 2 weeks just to make sure. The September one wasn't a fluke, but we haven't seen any seizures since, I don't even know, probably August of last year. Are we still candidates for any of the surgeries, or
I mean, you're,
just not
you're
make
certainly a candidate, right? As I said, it depends on what your goal is, you know? So if you came to me and you were like, I want to consider epilepsy surgery because I want seizure freedom, I would say, well, you already got seizure freedom, so I'm really not sure putting your child or loved one at risk of epilepsy surgery is really worth it because it's so unusual to get seizure freedom to start with. So, you know, why would we mess with a good thing? But if you were like, seizure free, but I'm on 3 meds, and I don't want them on 3 meds, I want to be able to get off some meds, then of course I would say, okay, well, the first thing we're going to do is try to get off some meds. I'm not going to do some surgery first, you know, because maybe you can get off the meds and you don't need the surgery. And so let's do that. And if we try to get off the meds and we can't, then we got to make a decision. Do we want to do the surgery to reach that goal or not? Or, you know, maybe there's some other reason for it. Another reason people might have sometimes is if the EEG, if they've had developmental regression and we feel confidently that the abnormalities on the EEG are contributing to that, and we have no other way to get rid of the abnormalities on the EEG, that might be, you know, another reason. So it just depends. You have to make that, you have to be clear when you go in what you're trying to do. And so often people think of epilepsy surgery as very black or white, seizure-free, not seizure-free. And they're like, if the person can't be seizure-free, they're not a candidate for epilepsy surgery, which is wrong. It's wrong. We had one more in the back before I move to the next topic.
So my son is 7 and he has hydrocephalus. So we're looking into the VNS and the RNS for his tonic-clonic, and he has daily focal seizures. So do you have advice for us? Because we are worried about the VP shunt. So they did do a case study to see, and he is complicated. So they're a little bit worried about doing either surgery due to his hydrocephalus and the VP shunt. And I haven't found any other families who also has hydrocephalus. And
Why are they worried? Is it a programmable shunt and they're worried there'll be some
it is, and where they
interference?
want to place the RNS, because he's so small right now, he has a smaller head size, so they're just worried about the room that he has available for all of the equipment that goes inside his head, essentially.
Okay.
So I'm just not sure, how do you really weigh the pros and cons of an invasive surgery like that, but not mess up something else that's been there since Bob's birth?
I mean, you know, just, I'm not a surgeon, so take this for what it's worth. But, I mean, the VP shunt sure takes up some space, but the RNS also, I mean, you have another hemisphere, so there's other skull on the other side you could put the device in if you needed to, and that's certainly been done before. VNS shouldn't be a problem at all, because that's not going to go in the head at all, so it wouldn't be a problem. So let's talk about, so that's good. Let's go into the different types of epilepsy surgery. Go through the whole list, okay? So the first types of epilepsy surgery, and what people traditionally think about when they think of epilepsy surgery, are focal procedures. So these are things like resections, all right? So this is, we have found in your brain a place that is responsible for your seizures, and we need to get that place out. So what we can do with that is we can go and we can resect just the abnormality, maybe something we see on MRI. We can disconnect it, so we can leave it in, but disconnect it from the brain around it so it can't communicate to it. We can laser ablate it. So laser interstitial thermal therapy is called lit therapy. This is we place a laser. It's guided, guided by magnetic or MRI, so we can see where the laser goes. Turn the laser on, the laser heats up the brain tissue. Brain cells can survive up to a certain temperature, and so as it gets hotter and hotter, we reach a temperature where those brain cells will die. What's great about laser ablation is that we have a lot of control over what's around us, because we can say how hot we need the area that we want to damage to be, and we can protect the areas around it and say when these get to this temperature, the laser has to turn off as a safety to prevent that. Laser thermal therapy is minimally invasive, so it requires about a 3 mm hole in the skull to place the laser in. The downsides of laser ablation, number one, there are longer procedures actually in the operating room because of how much time it takes to do the planning. The other downside is that the laser is a straight object that burns a cylinder, basically. So the lesion that we need to take care of needs to be fit within the shape of a cylinder that is all of about 15 mm wide. So we don't have a lot to work with when we're using a laser, so we have to have that for very, very focal areas. So procedures you would hear about in this kind of group are lesionectomies, meaning we see something on MRI and we're going to remove the lesion. Lobectomies, which means we're going to remove an entire lobe of the brain, so the temporal lobe, the occipital lobe, the frontal lobe. Hemispherectomies, where we remove the entire hemisphere, is another approach. Another one that a lot of you guys have brought up already is corpus callosotomy. Corpus callosotomy is a procedure where we disconnect the right and the left sides of the brain from each other. They are connected by a bundle of fibers called the corpus callosum. These are basically wires that help take communication back and forth between the two hemispheres. Many times in people who specifically have generalized epilepsy, so seizures that kind of come from the whole brain at once, the corpus callosum does a wonderful job of helping electricity get from one hemisphere to the other and causing seizures. So disrupting it can really help decrease seizures. There are several ways to do corpus callosotomies. The most common and traditional way to do a callosotomy is an open craniotomy. That is where the front skull plate is removed to expose both hemispheres of the brain, and the surgeon disconnects those fibers. Another way to do it is with laser thermal ablation, which again, minimally invasive. The downside is that the corpus callosum is a curved structure. And so when you have a curved structure and a straight laser, you have to make multiple straight passes to make a curve. So that means you're going to have multiple burr holes to make this curved structure. It does not work quite as well as open craniotomy, where you can actually visualize the corpus callosum, but it is minimally invasive. And then the third way to do it is through something called a mini craniotomy or endoscopic approach. So in this approach, you make a 1-inch incision at the top of the skull, then you go straight down, disconnect the corpus callosum back and forth, and you're done. That is my personal preferred way to do it because it is fairly minimally invasive. Recovery is good, and it works just as well. Corpus callosotomies, as I said, are traditionally used for things like tonic and atonic seizures specifically, but can benefit tonic-clonic and absence. There are some large series of people with LGS who've undergone callosotomy, with hundreds of people in the meta-analysis, and an average of, what was it, 70% of patients had at least a 50% reduction in their seizures, and 20% had a 90% or greater reduction in their seizures. So one of the conversations I have when I'm talking about callosotomy is that if I showed you all the medicines this morning, right, that are available. If you look at the rate of 50% seizure reduction across those medicines, none of them, they get close, but they don't pass 50%, except for clobazam. So compare that. You know, if you're on your third medicine, I would say, hey, this has a 50% reduction in 70% of people versus 40% in this medicine. Might be one way we'd look at it. Other procedures, vagus nerve stimulation. That is the most common thing that people do from an epilepsy surgery perspective, especially in LGS. That is it's like a pacemaker device. It's very small. It goes in the chest, left side of the chest, and then the wire ties to the vagus nerve that is in the neck. How does that work? Well, vagus nerve is attached to brain. and somehow stimulating the vagus nerve with electricity modifies and changes the way the electricity of the brain works. We have no clue how this device works, if I'm being honest with you. I think it's witchcraft, but it works for some people. The problems, the upsides of VNS are that it is a simple procedure. It's a day procedure. You go in, you get it, you go home. On average, about 50% of people that get a VNS get at least a 50% seizure reduction. And it can be used as a rescue. So you can swipe it and turn it on automatically. So people who are having a seizure can do that. And for some people, about 7%, it actually stops their seizures. So for some people, that's great. Downsides of, yeah. Meaning like a rescue. Like, so instead of having to use a benzo, right, you swipe it and you can stop it without having to get your rescue medicine. And that's the reason a lot of people get them, but I don't think it's often shared that number of people that it actually responds to is 7%. It's not huge. But for the ones it works for, it's great. Downsides of a VNS, side effect wise, you can get some cough, right, when the device goes off. It's because it's stimulating basically in your throat, so you can get some cough. There is a recurrent laryngeal nerve next to the vagus nerve, and so if that's stimulated, it can cause hoarseness. And if you injure it, it can cause permanent hoarseness. That's very rare, but could happen. Infection, like any surgery, but overall, it's a very well-tolerated device to get. The other downside I would say to it is that it is a device, medicines have a starting point and a stopping point, and so does a VNS. But the problem with the VNS is it has multiple different settings that can be changed, so it will take me a while to go through all the permutations of combinations of therapy. So I can control how strong the device is on, I can control how long it's on, how long it's off. So there's a lot of changes you can make. And data has demonstrated that, as with all neuromodulation techniques, is that you get more benefit over time. So a VNS, you can continue to see improvement 3 years, 4 years out. So I just tell people to think about that when you're talking about VNS, because it's easy, but it's also a commitment, before you really say it doesn't work. You're going to have it for a while. If you decide it didn't work and you want to get it out, you can take the device out. Many times we don't do that, but you can get it taken out. If you get it taken out, oftentimes they will leave the coil around the nerve. The way it attaches it is it wraps around the nerve, and over time that gets fibrosed onto the nerve, and so to try to take it off risk injuring the nerve. So we'd rather just leave it in place. And it's easier to leave the whole device in place because then you can get imaging. If you take out any piece of it, then you can't get imaging like MRI anymore because you have this free piece of metal in your neck. And when you have a device, you can't get chest, kidney kind of MRIs just because this area is not MRI safe with that device. And then the last neuromodulation techniques are DBS and RNS. So DBS is deep brain stimulator. A DBS is placed into the thalamus. The thalamus is the central part of the brain. It's kind of like the power strip, right? All the stuff in the brain connects into the thalamus before it works its way down the spinal cord. So it's a central hub, and in LGS and many other generalized epilepsies, the central median nucleus, which is part of the thalamus, is that central plug-in where everything comes into. So the DBS goes into the central median nucleus. And then an RNS is a responsive stimulator. So key differences here. DBS is kind of like VNS in that it's always stimulating, off and on, all the time. RNS is a responsive neurostimulator. So the RNS is recording EEG, and then when it sees a pattern that is a seizure pattern, then it stimulates to stop the seizure from manifesting. RNS can be placed in the thalamus as well. RNS can also be placed on the surface of the brain, so that is one of the approaches they're using for LGS, is to place one over the prefrontal cortex and leads into the thalamus. So that's another approach. Both of those devices have generators that are placed, the DBS is placed in the chest, the RNS is in the skull. So the RNS is only a couple inches big. They basically make a cradle in the skull and it sits flush into the skull, so you don't see it or anything. I mean, you can feel it, but you can't see it. I think that was all the surgical procedures I had. There may be more. There may be more. You guys have anything to add about
I had something I
or
wanted to add.
questions?
When I made the decision, what I meant to tell you guys is when I made the decision to go for Andrew's first corpus, he was having 6 to 10 atonics a week. And all of them, or if not most of them, resulted in some sort of injury. He ended up with staples in his head. He lost 2 of his bottom permanent teeth that had already come in. He ended up with a split chin. So that was a driving force for me, is he was becoming injured in these atonics. And so there was not a medication that was helping. And for me, it's, again, quality of life for him is being upright and moving. So if in order for him to stay upright and moving, then the surgery was our option.
So when we took Billy for his VNS, this was 1999. He was the 18th person that had the VNS implanted at the Children's Hospital of Philadelphia. And we weren't really sure what we were getting into, I will tell you quite honestly. But we were very impressed because within about 6 months, we were seeing faster recovery time from seizures, although we weren't really seeing fewer seizures. The recovery time was better. He used to have a really slow recovery time from his seizure activity. But I will tell you quite honestly, lots and lots of tweaking of the settings, et cetera. It took 3 years to hit a sweet spot. And that was a rapid cycle of a very high setting, which meant lots and lots of battery replacements. So Billy has been getting, the batteries are better now, okay? Batteries are better now, they last longer. But Billy generally would get the battery for the VNS. They would have to go in and replace the battery, we call it, about every 18 months because he would have so many seizures going off and we would be using it so much. So it's important, a lot of families, I talk to families all the time looking at a VNS and they want information. I tell them you have to be patient, you have to try this, you have to be willing to have the settings adjusted, and you have to give it time. Without giving it time, there's no sense going through the surgery. It doesn't make sense to do that. You wouldn't go on a medication, give it 6 weeks and say this isn't gonna work, we're gonna stop it, unless you had an adverse reaction. So, you know, give it a chance.
Okay, great. Now we can just take a little time. This is where you can like ask those questions you've always wanted to ask about these procedures, but you didn't want to ask maybe, or you forgot to ask. Do people have questions about these procedures?
All right, so we're on like year 3 of the VNS. I wasn't a fan of the VNS, but I went along with it. Seizures are getting worse. Not that, I don't know if worse is the right word. They're different, and I don't like them. So then now we've been discussing about, okay, let's maybe look at doing DBS. In your experience, has anyone had success with a different neuromodulation device if the VNS didn't work out well?
Oh yeah, for sure, for sure. First of all, what kind of seizures are we trying to treat?
Tonic and tonic-clonic.
Tonic and tonic-clonic, okay. So, yeah, for sure. I mean, you know, the neuromodulation techniques are different. So you can expect, just like with different medicines, that you might get a different, a different response. I think, to me, DBS and RNS makes more sense to be more successful, honestly, because, you know, as I said, a VNS is stimulating a nerve that happens to be connected to the brain. Those devices, RNS and DBS, are at least stimulating a nucleus that we know is involved in the network, you know, the EEG network. So theoretically, it makes more sense that it ought to help more. I think that we're still learning about those devices and how they are, how they are used and how well they're going to work. But they certainly do work. And there have been plenty of people who have a VNS and have those devices.
Yeah, I'll say 4 years ago, I was like, look, I went to this conference and they talked about this DBS.
Yeah.
I think this sounds really good, but they hadn't used it at all at Cincinnati Children's. And I was like, well, my kid's not going to be your number 1 guinea pig, but we can be like guinea pig number 12. So that's kind of where we're at, but I'm not happy with the VNS.
Yeah, okay.
So my son does have a VNS, and we've seen huge improvements
Yeah,
in
and some
his
people do.
cognitive.
And it's hard to figure out how to predict that. That's what just drives me insane.
Yeah, it's helped with seizures too, especially recovery time and duration.
Yeah.
But cognitively, I feel like we've gotten the most benefit. So I'm interested if there's any data in the difference between the RNS and the DBS in cognitive improvement.
So I'm trying to think. Offhand, not that I can think of. There was a recent review article that looked at the data that's out there right now on RNS and DBS and VNS. VNS had the most data in that kind of realm of non-seizure stuff like cognition, behavior, that kind of stuff. Most of what is in DBS and RNS is really from the clinical trials, and generally when they design these trials, they're doing things to show that it doesn't cause something bad. They're not looking for, does it cause something good other than seizure reduction? And so they can tell you that, for example, I think there was a slightly higher rate of like depression but these are, not LGS, but people that got the DBS, a higher rate of depression and things like that. It's really hard with LGS because it's hard to do those kinds of, cognitive tests for a lot of people anyway, and what happens when they put cognitive tests like that in LGS trials is that a lot of people that complete the test score at the floor of the test, right? So they're below the lowest score. And so even if they improve, you won't know it because they're still below the bottom score. And so you can't measure it really well, which is why there's a big push to develop new ways to study that, to realize the inch stones that people change and not the milestones that they're used to looking for. Yeah.
Real quick. So Billy has DBS as well as the VNS. And we went with the DBS because we were between a rock and a hard place. He was falling apart. His fine motor skills improved dramatically almost right away because they use it for Parkinson's, right? So his fine motor skills were great. What we didn't anticipate is that his cognition dramatically improved for him. Okay, I'm not saying that's for everyone, but for him it did. Unfortunately, about 6-7 weeks ago, we saw a sudden decline in his cognition, and we don't know why. So we're watching. We also saw a new seizure appear, and we don't know why. Is the battery dead on the DBS? No, we just had it checked because that was one of the things we said. But we don't know what's going on. But he has a teacher that comes every day during the week. His staff person is a teacher, and they do online work and whatever. His scores have gone up steadily. He's still on a first grade level, okay? But he's learning. And then all of a sudden, a little while ago, it stopped. The end of December 23.
We had a similar outcome with the VNS. We don't see any decrease in her seizures, but her cognition cleared up. She has empathy that she never had before, so we don't regret doing the VNS at all. But the first time we talked to a neurosurgeon, they recommended not doing the corpus callosotomy for her because she's too high functioning, and he said the risk of her losing abilities would be higher than the reward. What is your...
Yeah, so that's a good point. So corpus callosotomy, what you are, the types of things you're likely to see from a corpus callosotomy, or more likely to see. One would be disconnection syndrome. So when you disconnect the hemispheres from each other, you can present with several symptoms. One is right-left confusion. So if you're a person who understands your right and your left side, you can have some confusion there. If you're a person who's able to read, then you can have some difficulties with that because the fibers from your eyes that have to cross into the part of your brain that helps you interpret what the words you just looked at mean can be cut with a corpus callosum, so you can have some problems with reading. People who eat by mouth may have decreased appetite immediately after the procedure. That generally comes back. You can have, as I mentioned earlier, an apraxia. So one of the things we see after callosotomy is something called abulia, which means a complete lack of emotion. And so, a person who goes in, that's one of the things that, I always warn families about, because obviously, one of the main things people always say is, as many of you already said, I don't want my child, changed, and when they come out and they have no emotion, you're like, oh my goodness, they're changed. That is like short-lived. Like, we expect abulia to happen. That's how we know the corpus callosum got cut all the way in half. But then it comes back generally days later. So those are the main things. You can have some gait problems too that sometimes require rehab. And it doesn't matter which approach you use for the corpus callosum, that adverse effect is present in all of them, because all of them cut the corpus callosum. So it doesn't matter how you do it, and they don't decrease that if it's going to happen. But it's probably only, I don't know the exact percentage, but I'd say probably 20% or less in general, in my experience, have those adverse effects, and most recover really quickly. And then, a lot of kids, a lot of people that get corpus callosotomies, aren't able to walk and do have G buttons, and so those adverse effects become a little less of a concern for them, I guess. But so that's why people, when they have a higher functioning person, they're a little bit more worried about it. But you recover from those things almost all the time. Yeah, one here, and then I'll come to you. Or do we have one over here? Sorry.
Yeah. So we have never actually been spoken to about any surgeries before other than the VNS. Her neurologist has never really brought it to our attention. But after speaking to multiple families, I'm just kind of curious what surgery would be best for, because she has mostly tonics, absence, and myoclonics. Those are the three that we see daily. So I'm just kind of curious of
of those seizures, which one pisses you off the most?
Tonics.
Okay. And which one after that?
The absence.
Absence. Okay. And myoclonics, you could, whatever. Okay. Well, the answer about what surgery we do really depends on a few things. So I favor callosotomies. Why do I favor callosotomies? I favor callosotomies because the way my surgeon does it is with the mini craniotomy approach, which I think is very well tolerated, number one. Number two, callosotomy is a thing that either works or it doesn't work. And you find out the next day, basically, whereas an RNS or a DBS, which I think are also viable answers depending on what your goals are, might not give me an answer for a while, because of all the changes I would have to make to it to get it to the right setting. So that's why I would favor a callosotomy as generally my first choice. Again, it also depends on the patient. So knowing the risk and deciding, are those risks unbearable to consider versus that. So that's generally the approach I would take. I think VNS is also, reasonable. VNS, same thing. It could take a while. Some people respond to VNSs right away. Don't know why, and I don't know who they are.
Yeah, she has a VNS. That was the first. That's the only one that he ever suggested to us.
Yeah, surgery is also, it's one of those things where a lot of, it's not even sometimes the physicians don't know that surgery might be good for you, but especially if they're at a center that doesn't do a lot of epilepsy surgery, we're real bad, docs are real bad about talking about things we don't know a lot about, because we don't want to be wrong or for you to find out we're wrong. So we just won't talk about it. So if you're at a place that doesn't do a lot of epilepsy surgery, they often don't talk about it because it's not what they do, Where are we going next? Over here.
So you mentioned something about minimal invasive callosotomy versus the open brain surgery. Pros and cons.
So pros and cons of the different surgeries for callosotomy?
Yeah.
Yeah. So
invasive versus
yeah.
taken out the skull.
Yeah. So this is we actually did a paper on this a few years ago to compare those three methods. So open callosotomy probably is the most successful from an overall seizure reduction, because it's a fully visualized corpus callosum. You have a pretty good chance of making sure you cut every fiber. I mean, it only takes one fiber connected for it not to work, okay? So open craniotomy is probably most successful. Mini craniotomy, where we make the 1-inch incision, is almost exactly the same outcome. And laser ablation is still good, but less than that. So that's kind of the order of likelihood to reduce seizures. Then from an adverse effect perspective, an open craniotomy, the traditional way many people do it, is most likely to require blood products in the operating room. It is going to have the most associated pain and discomfort after it, because it's a very big procedure to undergo. It has the highest rates of rehospitalization within 30 days of the procedure, whereas laser ablation has the least blood loss, but it is the longest time in the operating room, so you're under anesthesia for a longer time because of the complexities of planning it. And the adverse effects as far as getting disconnection syndrome, as I said, is the same for all three, because that's the result of cutting the corpus callosum. It has nothing to do with the procedure itself. I didn't mention earlier, there's 3 different types of corpus callosotomies. There's an anterior 2/3 callosotomy, which is exactly what it sounds like. We disconnect the anterior 2/3. There's a posterior 1/3 callosotomy, and there's a complete callosotomy. Complete callosotomies are the most efficacious approach to treating seizures. Anterior 2/3 callosotomies were invented with the intent that that disconnection syndrome I talked about would be less, because you leave some of the fibers in the back connected. And it is true, the rates of disconnection syndrome are less with anterior callosotomies, but they're not as successful. And then posterior callosotomies were invented basically because there were some instances, especially in higher functioning individuals, where corpus callosotomy resulted in adverse behaviors. And so the idea was, if you keep the anterior portion, which is the frontal lobes, which is in charge of behavior, connected, you'll have less behavior problems. And that is true, but there's not really a lot of people that just the posterior 1/3 does much for. So it's not very effective. So it's rarely ever used. Yes.
My question is about RNS. I want to know how much time take the recovery. What are the results for LGS patients? Like, how much time take RNS to start working? And if you can talk about more how are implementing artificial intelligence with the RNS, because I think I read something about Australia, another doctor, I don't know, I cannot remember, in other state that were using AI with RNS. Where are the best centers or professionals to do the RNS? Right now, I live in Florida. My daughter is in Old Children Hospital in St. Petersburg. I like the hospital, but they doesn't do a lot of RNS surgeries right now. So when the doctor told me, it's better because it's close to my home, but I want to choose the best people that can understand the RNS or are, very ahead of the investigations and the new technology and everything. So if I decide to do the RNS like in Texas or in other state, how we can handle like the appointments, how works after the surgery and they put the device, what I need to do in my home with my girl if I do that.
Okay.
I have a lot of, it's more RNS everything.
Yeah. That's a lot of questions about RNS. Okay, so let me see if I can remember them all. The first one was the recovery.
The first one, the recovery time.
A person who gets an RNS generally goes home the next day. You have to make the incision in the skull to place the device, and then the incision for wherever you're going to put the leads. But the recovery is pretty fast with relatively minimal pain, so most people go home the next day. Then you generally come back about a month after the device has been implanted to have stimulation turned on. So for the first month, we're really just collecting data so that we can train the machine to recognize your seizure pattern, and then we turn on the stimulation to start reacting to the seizure pattern. And then visits are on average every 3 months. to make changes. And then as we get to a setting that we're pretty happy with, we might start to stretch that out. What was your next question? Your next question was?
Okay, after we did the RNS, and we need to go to the appointments,
Yep.
how, I need to do something with my daughter, like have a laptop or
Yep,
something?
you'll have a laptop at home, so you get a laptop when you get the device put in, and you're asked to every day download data. So every day you put the wand over the device in the skull, you can see on the laptop that it's connected, it downloads the data to a site that your doctor would be able to log into and look at if they needed to, but that's where we store all the information. We ask you to download it every day because the device, it's like a memory stick. It can only hold so much information. So if you're having a lot of events that it's recording and stimulating, it's going to capture all of those, and then once it gets full, it'll start overwriting it. So it'll...
You need to do it like every morning, every night?
Whenever you...
Whenever?
I don't care when you do it, just as long as you do it. Yeah. It depends. So the first month for sure, because we want to get a lot of information, right? But you still need to download it kind of on the regular because it's really giving you information back, right? So not only does it give us information that might help us choose how we do the stimulation, but it also gives me information about what's going on in your life. Like I can look at the RNS and I can see like the number of seizures it's responding to every day, and I can see the trend, and are we going down? Are we getting less stimulations, more stimulations? We call them long episodes. That's what it reacts to when it sees a pattern that's a certain appearance and a certain time. That's what it reacts to, and so it records all that stuff. So the more you capture, the better. Now I have some people that have had it for years, and I'm like, you don't have to download it all the time. That's fine, but on some regularity, at least once a week, give me a data point to look at so I've got something to compare to. So, yeah. So what you would do, right, so you get it in, so you could do a few things. If you wanted to get it somewhere else than where your home is, they could still program it where your home is. The way RNS programming works is actually the company sends representatives to the clinics to help with the programming. And so essentially, most places that have epilepsy centers of any type can do programming.
But if I decide to do it in Texas, I send the information supposed to you. You need to program. I need to go to Texas so you can change the settings, or you can do it by internet and send it.
Well, no,
to the
you would just go to your
how
local
that
clinic,
work?
for instance. I mean, we've seen people frequently that have just come to us for implantation of the device, and then I send them back to their physician, and their physician does the programming. We don't have to do it. They can do it.
So
we can't do it remotely. It'd be cool if we could.
You can do the settings, and they are the people that put the new settings?
Yeah, they can change the settings, just like change VNS settings. You can go and they can change it. They do the same thing. They put the wand up there, they type in what change they want to do and program it.
And you send the information to them, like other doctors?
They'll get it from the company. So the engineers from the company are who help make the plans for how the stimulation works.
Okay.
That's why I
that
said it
is
could be
a good,
done. It could
so
be done
you,
at lots
the
of places.
doctors are not the persons that are looking the data. They have this.
We are looking at the data, but there are bioengineers from the company who also look at the data and help to make the plan of what the stimulation. It's a team effort between your physician and the bioengineers.
So when I send information to the doctor or to the bioengineers?
Well, you're just going to upload it to what is the site.
To the cloud.
To the cloud site, all right? And then we know when people are coming into clinic and we go in and do the analysis. Some people will do it on a schedule, like for instance in our clinic every 3 months we'll log in and read EEGs and look at the stuff for RNS. Some people don't do that, it depends.
So my next question is about the artificial intelligence.
Yeah, so
what do you know how they are using artificial intelligence and the RNS right now?
So there's a lot of AI it's like laser. It's a cool word. Everybody likes it, so everybody's doing something with AI. And RNS is just a lot of data, and so people are starting to look at these big collections of data and see if they can find patterns and waveforms and other things to stimulate that might be better than the things they are stimulating. I mean, there's still a lot of work. There's nothing in that that's, I would say, is like a breakthrough just yet, but yeah, people are doing it.
Yeah, I'm thinking because sometimes my daughter, we are seeing with the puberty in certain days with the hormone estrogen, or her seizures are increasing. So I don't know if they can see, those patterns. Okay, each 14, 17 days, she have more seizures. We can change the RNS.
Yeah, I mean, you can't change it on a schedule like that. Maybe one day we will be able to do kind of predictive stimulation and things like that when you see that things are building up, right? But it can't do that right now.
With the RNS, we don't have like a magnet to send more stimulation?
No, you have a magnet, but the magnet is just to mark things. So if you have a seizure and you want to mark it so that we can review it, you can swipe the magnet and it marks it in the machine so we know that that's an event that you wanted us to look at, but it doesn't do anything else.
Okay.
Over 10 years. I mean, it depends. It really depends on the setting, Like, I mean, like all of these devices, it depends on like how much is going off. But in general, these things last about 10 years.
Andrew has one. It was put in 2021. Because his seizures are so frequent and detected so often, he had a battery replacement within 3 years. And we had to change the settings down, which I wanted to argue with his new neurologist, like you can't do that because we've had such great control. But he said within 18 months we would have had another battery replacement. So it really depends on where how high your settings are at.
Sorry, my last question was, how are the results for LGS patient with RNS? Like, what is
Yeah, well, the LGS with RNS, I think we're still gathering the data on that. I would say in general about 50% have at least a 50% reduction of seizures. I think it's going to be better than that. 50. I think we have it's on the handout, right, that we made. We have some stats on there from some of the studies, right? Yeah, 60% in that particular study had a 50% reduction of seizures. But that's going to get better. I mean, this is just starting where people are starting to use it more often for LGS. So I think we're going to have a much better understanding later.
Yeah. Okay, I have a 22-year-old son who he's on 5 medications, has a VNS, and I think I just need kind of like I have a skewed perspective because historically we've had periods where he's had very difficult times of like seizure after seizure, hospitalizations, respiratory distress, intubations, all those things. So right now he's like averaging 1 to 2 seizures a day, tonics and tonic-clonics, and some absences, which we were like whatever with that, but comparatively. We've been asked to consider an RNS or a DBS, and we have our appointment coming up. So I just really am wondering, when other families come to you, are they coming to you with, their loved ones having 1 to 2 seizures a day, or are they having, like he was previously, like 10, 20, 30, or, are we, again, looking at, maybe people that are looking for things to relieve some of the other symptoms like the fatigue or things like that. So it's just kind of like getting that perspective on, like, how many seizures is okay to have at this point,
Well, I mean, that's an answer that really only, the family can answer, I see people that have, a few seizures a year that would get epilepsy surgery, right? I mean, it depends on your situation. It takes a couple seizures a year not to be able to drive the car all year. So that's not control, right? And we can get rid of that. In LGS, sure, they're often having more, right? Because they have tons of tonic seizures every day and other things like that. So most LGS folks are having a ton, but whatever. Any number is a number. It depends on what your goal is. And if those two are impacting quality of life and having less than those two would make it better, then it's worth considering that option.
I have one over here.
I have a very similar question. My son is a similar age and a similar profile, used to be in very dire condition at different points several years ago, now has VNS and a cocktail of 5 that, life is, it's okay. It's not awesome, but it's, way, way better than it was. So if it was your kid, or, would you be thinking DBS or RNS as a, hey, like, let's just keep fighting down the curve, or would you be more like, you know what, this is, and I appreciate that's ultimately, as you said, the family has to make that call, but is it worth the fight, I guess?
I mean, I think it is. I think if you've got, like I said, seizures or something else that's really impacting quality of life, and specifically with seizures, reducing the seizures, you think is going to improve that, I think it's worth doing. I mean, I think the risk of these procedures, especially RNS and DBS, is quite low. Epilepsy surgery in general has very low risk as far as like mortality, like death is incredibly uncommon in an epilepsy surgery procedure. Severe adverse effects like strokes and injuries and like that are also quite rare, not impossible, but rare. And with DBS and RNS, I think it's really low. And yeah, I mean, I think it's reasonable to keep trying to get better, but you have to consider those risks and that benefit and decide if it makes sense for you. But I would do it for my kid, to answer your question. Why choose one over the other?
I mean, it seems like the RNS, because it gives you a real-time recording of live EEG, basically, that even if you're manipulating medications, I can download it, let them neurology and hospital.
Yeah.
They'll go on and they'll look and they can tell versus DBS. You're not getting that same benefit. With Andrew wasn't off the books, like whatever.
Yeah.
He's got an RNS with the leaf deep in the thumb. So what is, when you're sitting there and you're saying RNS versus DBS, what is the, I guess for these guys, what is the difference and why is one better than the other?
Yeah, so, okay, I mean, that's a great question. I don't really know that one is better than the other. Really, when you're trying to choose RNS and DBS, it really comes down to the center you're at and where their expertise lie. So if you came to see us, I'd put an RNS in. Why? Because that's what I use. I use RNS all the time. I don't program DBS as much, and so I'd rather use something that I'm very familiar with doing. You go to Colorado, Colorado does a lot of DBSs, so you're gonna get a DBS there. And whether one is better than the other or not, we don't know. There's no direct trials of the two. So the benefits, as you said, is the RNS does record. So you've got some kind of, EEG recordings and stuff that you can really track. DBS is going to record also. So that is the new version will have the ability to record. So that will be there. I think from a theoretical perspective, there's differences between the two. As I said, a DBS is like a VNS in that it's always off and on stimulating, right? So to me, that would seem like it might be a better approach because it's always stimulating. And so if it's always stimulating, modulating activity, hopefully that prevents the seizure from ever occurring. Whereas an RNS waits until it sees the pattern and then it reacts to try to stop the seizure. But the thing is it reacts incredibly quickly. So it reacts before you would see anything clinically anyway, usually. So, I mean, for that reason, they're very similar in that way. What's that? Oh, and the stimulate, yeah.
So with these procedures, what's the chances of a loss of cognition? My granddaughter she's extremely smart, but she has all these seizures, and even to consider one of these procedures, what's the chance that she'll lose some of that cognition with the procedure?
So, as I said, it's tough, especially when we're talking about LGS specifically. It's really tough to say on individual procedures because these studies aren't designed to do cognition because the tests aren't adequate to study cognition to start with. I will tell you in general across the entire epilepsy surgery landscape, people that are the highest functioning people have the highest likelihood of cognitive decline following epilepsy surgery because they've got much more to lose. Whereas people who are lower functioning have the highest likelihood of gaining cognitive score because they've got the most to gain. I mean, there's definitely difference in like a resective procedure, right? So if you're resecting and removing something or disconnecting something, that's going to have a higher likelihood of an adverse effect of cognition or something like that because you're removing functioning tissue potentially, right? Whereas a neuromodulation device, everything remains intact. So the likelihood of any kinds of effects with that is much less. Really, if you're going to have a problem with that, it's probably because there was some adverse effect from the procedure itself. Like it's not the device, it's that putting it in caused something, you know, some. It is, well, it's a disconnective procedure, so I guess I would say it would fit into the category of a higher chance, though I would say the chance is actually quite low. Where am I going here?
If you
Here, okay.
So 2 quick questions. Well, maybe not quick, but so I know I've mentioned that our recommendation from our neurosurgeon was colostomy, corpus colostomy, and we have talked with them about like doing maybe some of the devices as like a stepwise, like less invasive permanent procedure, and their philosophy is kind of like go big or go home sort of thing. And so how, like, I don't like, that's not like, that's an interesting mindset to take and sort of thing. And like, I'm normally like in like other things, but something this permanent, like, how do you manage that sort of mindset of like, their thinking is do the corpus first. If that doesn't work, then look at the devices. Because one, if you do the devices and then go corpus, the device is in the way of doing the surgery.
Yeah.
So it's a little bit more technically challenging. But just how do you kind of do the mindset of stepwise versus go?
Well, like I said, there's a few things to think about there. Number one is it depends on like what the goal of the surgery is, and a callosotomy will give you that goal immediately if it's going to work, whereas neuromodulation may not, and it may be a while. So that's one thing that has to be considered. Another thing that has to be considered is that if the callosotomy works, and then you're done.
Yeah.
Or I put a device in, you're not done. Like you're going to keep coming back for, you know, to get that thing, you know, programmed, to get battery changed. You know, that's a lifetime of having to work with that device. So there's a bit of a commitment there. What you said is what many surgeons would say is that if a callosotomy is something you think you would do or want to do, you should do it first, because once you put the device in, it's in the way, and it makes the procedure more complicated to do a callosotomy once the device is there.
Got it. Just and the other question is, if we do, so the main thing they're saying was like the drop seizures were different types, but is there any value, because she's controlled by known medication, is there any value of weaning her off the medication to see if those seizures will come back before the surgery? I know like our neurologist was concerned that if you wean her off, she has seizures come back. Sometimes the medication, when you reintroduce it, it doesn't control it. So is there any value of weaning her off to actually see if she still has the surgery?
Yeah, I mean, well, like I said before, I mean, if I had a kid who essentially was controlled on medicine, and then we were thinking about doing something with callosotomy because we want them on less medicine, well, the first thing I would do is just see if I could have them on less medicine, because maybe I could have them on less medicine, they still don't have seizures, so why would I do a callosotomy, you know? So, yeah, I do think you have to prove it. Like, you have to prove it's needed.
Yeah, and I mean, they probably want themselves improving going off medication, but at that point, what do you do?
Ask somebody else. I mean, unless you're happy with that answer, which is fine too, but I don't know. I don't know.
Okay, I think we need to cut it off.
Yep, no worries.
Thank you so much for everyone for coming, and a round of applause for Jamie and Diana, especially Dr. Perry for being here and answering all the questions.